Alrighty, so now we're moving on to EKG and lethal arrhythmias. This lecture is going to not be as long as the first lecture. We're going to discuss identifying arrhythmias and kind of go over the big arrhythmias that you should be able to identify when you're looking at your EKG. First, we'll just quickly go over some basics about arrhythmia and interpretation. And then at the latter part of the lecture, we'll do some practicing. I'm going to make all these slides available to you, so if you'd like to print out the slides before listening to the lecture, that way you can write notes and you can go along and try to do some of the arrhythmia identification. We'll do that towards the end of the lecture. I'm just going to quickly go over the conduction pathway of the heart. I know we discussed a lot of this in great detail in the previous lecture, but I think it's just a good recap for anyone who might have skipped the first EKG lecture. For your action potential, we're evaluating the ability of the heart to create an electrical impulse and go through the AV network in order to really innervate the heart muscle to pump adequately. You have the SA node and the AV node hosting a collection of pacemaker cells. These pacemaker cells, they really have great control of the conduction of the heart, and if something happens to the SA or the AV node, there are scattered pacemaker cells throughout the ventricles that will spontaneously generate impulses. I have listed up here inherent pacing or rate of pacing. As you can see, when you go from different parts of the heart, from the SA to the atrium to the ventricles, you have a slowing of the inherent pacing that these cells will auto-generate. And although it's really undesirable, the AV and the ventricular pacer cells pacing at such a slower rate of 20 to 40 or 60 beats per minute, even though that's not, what we would like to happen, that electrical impulse can act as a failsafe, and it can help a patient survive until a change can happen. It can sustain life for a little while. So that inherent rate of pacing is a failsafe of the heart in order to keep on beating in the event that there is a major block in the electric conduction pathway. I have listed here automaticity versus conduction. The heart tissue is synchum tissue, meaning that the tissue properly relates all of the electrical conduction throughout healthy heart tissue. Once one myocardial cell accepts an impulse, it passes it along to its neighbor cell in kind of a ripple-like format. So once that conduction is started, it passes off through all of the innervated tissue. That synchum tissue all kind of is interconnected. You end up having all of the myocardial tissue pass that conduction with depolarization of the cells in a healthy heart. Depolarization generally happens after the conduction of those Purkinje fibers, but if some other area starts that electrical conduction, such as with VFib, you start to have a quivering or some confusion about how this tissue is supposed to beat together. When you're looking at this chart over here, kind of looking at the electrical pathway and how it's related on the EKG with PQRSTU, it shows the P wave. That P wave is the atrium depolarizing. QRS is the ventricles depolarizing. Now when the atrium start to repolarize, that's usually not seen on the EKG because there's such a larger activity of electrical activity for the QRS that the QRS kind of covers up that atrium repolarization. And then you get this T wave. That T wave represents repolarization of the ventricles. So you have PQRS for depolarization, you have a hidden repolarization of the atrium, and then the T wave is that repolarization of the ventricles. QT interval, there used to be like a set, this is a normal QT interval. However, your QT interval can be a little bit different based upon gender, body habitus. So when we're looking at QT interval, we really want to be able to compare the QT interval based upon a previous normal. So if you can have a baseline EKG for every patient, that's great, because if you have a baseline EKG at a patient when they're at their healthiest doing an annual visit, that can kind of give you a baseline as far as what's a normal QT interval for this patient, especially when it comes to prescribing medications. Generally, you have specialty providers that may be providing digitalis or other antiarrhythmic medications. However, you may want to know that your patient has an already prolonged QT interval before starting a fluoroquinolone antibiotic or something like that, because that could be good information on your prescribing practices. So it's good to have a baseline so that you can always make comparisons when we're discussing QT interval. One other thing that I wanted to note is there is a very vulnerable point during the repolarization of the ventricles. When your ventricles are repolarizing, an electric shock during that time period causes a R on T phenomenon, which can cause arrhythmia and a lot of confusion through the heart tissue. So this point right here where it shows the ventricles repolarizing, where I have the electrical bolt, we want to avoid any kind of electrical shock during that time period. This is covered detailed in ACLS, which I'm not going to get into ACLS information deeply, but that's a big reason why we need to have a patient hooked up to a monitor and evaluating their rhythm before doing any kind of pacing or electrical impulse shock. Staying consistent in our evaluation method really keeps us on the ball. So I want all of us to kind of use the same format when we're identifying these arrhythmias. The more arrhythmias you evaluate, the easier this gets. I'm not going to, read through this. I'll let you read it yourself. This was really discussed in the first lecture, but we'll use this kind of evaluation method as we're going through and looking at these arrhythmias. We'll start off with normal sinus rhythm. This is what you should expect on a healthy adult with no problems and functioning conduction system. We have a P that leads every QRS. They're all the same shape or morphology. That morphology means the waves that are coming from the same place. Different shapes or morphology means that the impulses are coming from different locations. So that's something that you should kind of have at the back of your mind, especially when we get into VFib or VTAC and things like that. If you see a P for every QRS, this generally means that you have identical rates for the atria and ventricles. So that's always a good thing to have. Looking at this PR interval, it's a normal PR interval. It falls within that criteria. The QRS looks normal. There's no axis shift that we know of because you need a 12 lead to determine axis shift. But I'm just going to tell you for right now, we're not discussing that until we get into the 12 lead evaluations. Looking at each lead group, looking for any ACS changes. Acute coronary syndrome, we can evaluate that when we're looking at the EKGs 12 leads as well. We're going to be looking for these T wave changes, ST segments, or pathological Q waves. This is normal sinus rhythm. Whenever we see this kind of arrhythmia, we need to look at the patient and evaluate the scene and see if this is true data on the monitor, along with evaluating this on a second lead. Patient should have a crash cart in the room getting everything ready for a code situation if you see something like this. Generally, this is a pulseless arrhythmia, and you're going to need to start CPR immediately while you're calling a code and getting people there that can help you resuscitate the patient. As you're looking at the EKG, you note that it's chaotic. There's no discernible waves or complexes. You can't identify P, QRS, or T complexes. It's all just messed up. Now, sometimes you'll have a differentiation of coarse versus fine. This is really kind of detailed here well on this strip, where you can see the coarse VFib going up and down, and then the fine VFib. Sometimes the fine VFib can be misinterpreted as like an atrial fibrillation. So those can be, difficult to discern at times. This is a shockable rhythm. So generally, cardioversion is easier on a patient with coarse VFib than fine VFib. Epinephrine is one of your first ACLS drugs and can sometimes improve conductivity and coarsening of that EKG. So a lot of times we'll be doing that kind of intervention as soon as possible. Whether shocking is happening with defibrillation or cardioversion of another arrhythmia, the hope in shock therapy is that you want to depolarize all the cells in the myocardium, which allows all of the cells just a little respite and the ability to repolarize. All providers then hope that the SA node would take over and create a normal path of conduction after cardioversion. This isn't always the case. There's usually multiple factors involved, and the thing is when you see fibrillation, this is something that needs to be shocked and have attention to immediately. Okay, looking at this rhythm, we're not able to see any P's. What is happening here is we have wide QRS after QRS after QRS. These wide rhythms are being started in the ventricle, and there's a little bit of a longer time period in the ability for that electrical impulse to flow through. So that's why you get that widened QRS. And having so many beats all at once doesn't really allow for the heart to fill up with blood so that it can pump. So sometimes we'll have a pulse and sometimes we won't have a pulse with VTAC. You want to evaluate your patient and what's going on in the room. You might have a patient that has this and has maybe a little bit of chest pain or shortness of breath, but they're alert and oriented. If you have a patient that is, awake, alert, and oriented, but has a true VTAC that is sustained, intervention needs to happen immediately. And, the possibility of sedation may be necessary. That's going to be up to the prescriber and whoever is leading the code, because this is an ACLS code type situation. You can have monomorphic VTAC, which is seen here. You see that all of the complexes look pretty much the same. They're all coming from the same origin, and you can see how it's all pretty consistent. Whereas you can have polymorphic. This is more of a torsade de pointe type distribution here, where it has that echoing, smaller, bigger waves. Torsade de pointe also has, this added measure where they need magnesium supplementation generally. So whenever you see this large widened VTAC followed by shortened, followed by widened, enlarged, you want to think torsades, magnesium, ACLS all together at the same time. Now a VTAC that's monomorphic like this, you can get a good rhythm, a rate on it, so you can actually have a good heart rate. Whether they're perfusing or not is another question. A beat like this over here on the right hand side, where it's polymorphic, it may be harder to differentiate what kind of heart rate is going on, and that's not going to be as helpful anyway, because what we need to do is shock and provide resuscitation to this patient. Asystole is a pulseless condition. It has very low chances of recovery. Sometimes we're able to return circulation spontaneously through ACLS measures, and sometimes not. It's not a shockable rhythm. There's no discernible complexes, there's no P, QRS, anything. This needs to be confirmed on a second lead. This could be a very fine VFib. Sometimes evaluating on another lead can be very helpful, and that's why 12 lead is great in its ability to really help provide some more data to your decision making. But these are all code situations so far. Pulseless electrical activity. This is where you have what appears to be good conduction, because you see P, maybe QRS waves on your rhythm strip, and the patient doesn't have a pulse. So you go in to evaluate your patient, everything looks okay on the monitor, but they don't have a pulse and they may not be breathing, probably not. You need to have CPR initiated immediately and get ACLS started, and search for reversible causes. Over here I have the H and T's that are listed. H and T's are talked about through ACLS training, and these are some things that you'll want to consider and rule out as far as a cause for pulseless electrical activity, along with some of these other arrhythmias. Ideoventricular rhythm. Looking at this strip below, you see these inverted tombstones pretty much. This is a idioventricular pace rhythm. When we talked earlier about the fail-safe, where your heart tissue can create its own rhythm even if it doesn't have that impulse from the SA-AV node conduction pathway, this is kind of getting into that realm. When we're looking at this, it's important to note how long it's taking for this rhythm to go from impulse to impulse. And a lot of times this is going to be written out on your 12 lead EKG. So when you're looking at your 12 lead EKG, it may say already that there's 57 beats per minute for this idioventricular rhythm. But sometimes the EKG machine will read a strip, and it may have difficulty due to artifact or abnormal rhythms on getting an accurate beats per minute or heart rate. So it's important that you know how to calculate a heart rate based upon looking at this. Remember that each small block is about 0.04 seconds and each big block is about 2 seconds. So 5 big blocks are 1 second. Okay, so stay with me, trying to think about, counting and all this kind of stuff. In 1 minute, you have 300 big blocks. Okay, so 300 big blocks for 60 seconds. So to get a beats per minute, you can take that 300 block and divide it by how many big blocks this rhythm is taking up. And if you look at this rhythm, you got 1, 2, 3, 4, 5, and just a little bit. It's about 5.2. So we'll divide 300 by 5.2 to get 57 beats per minute. You can do the same thing by dividing it into little blocks. So if you want to go through and count all these individual little blocks, if you got 1, 2, 3, 4, 5, you got 25 if you have 5 in each big block, and then you got one extra one, 26. So 1500 divided by 26 will give you your beats per minute as well if you want to do it by little blocks. This reverse tombstone pattern can be an accelerated idioventricular rhythm, maintaining a good cardiac output, and it can probably drag on for quite a while. Some people can, sustain an idioventricular rhythm and perfuse for a while, whereas many other times this is a poor cardiac output despite it being regular and consistent. This is eventually the patient's going to crap out and not be able to perfuse their cells, and this is going to cause problems. Generally, there's an underlying atrial rhythm dysfunction. We need to treat the underlying condition. Atropine needs to be probably introduced to subdue the sinus rhythm, and ACLS intervention needs to happen. This is usually, a decision that's going to be by cardiology, especially on a stable patient. And if you see this patient in the outpatient center, they need to go to the ER for emergency treatment. This can be related to toxicity, MI. These patients can deteriorate quickly, so it's important that this patient gets seen immediately. So now we're moving into more atrial arrhythmias. On the previous slides, we were talking more about ventricular arrhythmias because there weren't any P waves in those strips. Now we have P waves followed by QRSs, which means that there's a good conduction pathway from the atrium to the ventricles. Recognizing whether or not this is a lethal versus a non-lethal arrhythmia, it really depends on the circumstance. What are the causative factors? You can have a patient that gets their heart rate up into the 110s, 120s when they're exercising, like this man running on the side of the road, and that's a normal finding for someone. Someone that's having chest pain or they're inpatient, we want to look at what are the causative factors to having such a high heart rate. Is this possibly, some sepsis or some other causative factor for this arrhythmia? Do we have other issues at stake here? Okay. This is not a shockable rhythm. There's no need to shock. There's a good conduction throughout the heart. Looking at the rate of this strip down here, if we look starting at, you can start at the P or the Q. I like to start generally at the QRS to QRS to QRS. It looks like it's about 1, 2, and maybe 1 to 2 little blocks. So 2 big blocks and 1 to 2 little blocks. We'll just say that it's 2 big blocks, 2 little blocks. So that's 2.4. We're going to take 300 divided by 2.4, and that gives us 125 beats per minute. Okay, so we have our rate, 125, which is over 100. So this is looking like sinus tachycardia. Any kind of weird changes with the amplitude or any other kind of interesting information. Looking at the isoelectric line, we don't see a big dip or raise in our T segment, ST, so that's good. We would need to look at the whole 12 leads to see if there's any kind of axis changes or signs of acute coronary syndrome. But we can be pretty sure that this is sinus tachycardia. We want to treat the underlying condition and prevent cardiac damage. Whenever our hearts are beating this fast, it's difficult for them to fill and to reperfuse. So slowing that heart rate down will help preserve muscle function over time. Moving on to the opposite end of the spectrum, sinus bradycardia. This is a very slow heart rate. The atrium are throwing out a really slow impulse throughout the heart. By definition, sinus bradycardia is atrial rhythm with P waves that's slower than 60 beats per minute. We want to think about circumstance where causative factors, making sure there's no head injuries or other kind of conditions that could be causing bradycardia. Some athletes can be really fit and they train daily, and they may have a very low resting heart rate in the 50s. That could be normal, but when we start to see a heart rate like this that's very slow, that is concerning, and we need to follow up and treat any kind of underlying conditions. The biggest problem with this heart rate is, are we perfusing the body sufficiently? Can the heart pump adequately in order to push the blood throughout the body at such a slow rate? When we're looking at whether this is shockable versus not shockable, this is not a shockable rhythm. What is the rate? Okay, if we're looking between our P waves or QRSs, it looks about 1, 2, 3, 4, 5, 6, 7, 8. It's about 8 big blocks in between. Let's count another one. It's about 8 big blocks between the third beat as well. So we'll take 300 divided by 8, and that's about 38 beats per minute. So this is a significant bradycardia. The difference really between sinus bradycardia and heart block has to do with the distance between the PR interval. When we're looking at PR, is there a P for every QRS complex, and is it getting to a point where it's elongated and over the normal PR interval? That's where we're going to be evaluating whether or not this is heart block versus sinus bradycardia. I know some people struggle with AV blocks, so I'm going to try to simplify this as easily as can be done. When we're looking at the AV blocks, you have first degree, second degree, and third degree. Okay, first degree AV block, you still have a P for every QRS. Once we get to second degree AV block, we start to lose some QRSs for our Ps. And then once we get to third degree AV block, the P's and the Q's are not communicating at all with each other, which causes chaos, and looking at that block, it can be kind of confusing when you're looking at the strip. And I'll kind of talk about a good way to evaluate how to see if there's a third degree block. Okay, so first degree AV block, you have a P for every QRS. The problem is that it's taking way too long for the P wave to initiate to that ventricular depolarization. So that PR interval is greater than 0.2 seconds, or one of those big blocks. With heart block, it's important to note that the rate and the rhythm needs to be written down in your report or your evaluation or assessment of the EKG. You don't just say that, this patient's in first degree AV block. You would notate, the patient is in normal sinus rhythm with first degree AV block for this rhythm strip up here. That would be a good explanation, because that patient's heart rate is within a normal 60 to 100. In the past, this type of heart block was not as concerning to most providers. It was thought to be fairly benign, but more recent data collection has shown the propensity to developing arrhythmias such as atrial fibrillation directly related to this type of first degree AV block. So if you have a patient in first degree AV block that's asymptomatic, they may just need to be evaluated by cardiology and get some follow-up monitoring. Much alike to first degree AV block, Mobitz 1 or Winky Bach, as I like to call it, generally does not progress to a lethal arrhythmia and is usually monitored by cardiology specialty, but it is something worth noting and evaluating the patient. This pattern can be seen in a longer strip, usually easier than is shown here, because you're able to see that a longer drop evaluation. So what we see is here you have the PR interval at the beginning of this second degree AV block or Mobitz 1. The P to the QRS is, okay. Then that second beat, that P to QRS is a little bit over that 1 big block range. And then this third beat, that P wave is getting longer and longer before that QRS happens, until finally you have on this fourth one, you have a P wave, but there's no QRS. So the way that you can kind of think sing-song in your head is longer drop than you have a Winky Bach. So it takes a little bit of time and you see a longer PR interval until eventually the QRS is just, it doesn't happen. Okay, then you might have a recurrence of it, but that's a second degree AV block, Mobitz 1 or Winky Bach. Second degree AV block Mobitz 2, or out of the blue Mobitz 2, this one is fairly serious aberration strip. Some key differences between type 1 and type 2 are related to the PR interval. Generally, the PR interval stays consistent. Each QRS is preceded by a P wave. However, not every P wave conducts a QRS. So you have some obvious conduction issues where, P wave goes, QRS, P wave goes, QRS, P wave, and it's just dropped out of the blue. There's no elongation of the PR interval. It's just a QRS, a whole beat is dropped in the ventricle. This can be a serious problem, especially if it, starts to worsen, as it sometimes does. With Mobitz 2 and Winky Bach, you can also have a 2-to-1 block where you have a rate of how often the heart rate is, or that QRS ventricle depolarization is dropped. This one on the fourth strip is a second degree block, 2-to-1. So for every 2 P waves, we get 1 QRS, which that drops your heart rate in half. That can definitely affect your perfusion ability and can lead to some very serious outcomes. Now, third degree AV block with your junctional escape. The junctional escape is talking about that ventricle starting to fire off and go on autopilot because there is no communication between the atrium and the ventricles. So the atrium are beating, they're sending out their message thinking everything's good, and the ventricles are beating at their ventricular paced rhythm. The way that you can tell that this is a third degree AV block is you can get a ruler or some sort of measuring stick or a piece of paper and make some marks on it. You want to evaluate the P waves and see where the P waves are lining up. You will notice that in the strip, the P waves are going to be very consistent, where the P waves are coming out at the same rhythm generally, and you can see these P waves marching through the junctional rhythm. Sometimes you'll see it where the P wave falls on a ventricle depolarizing, and it may be kind of hidden or right along the side of it. But you see that there's 2 separate circuses going on at the same time, but they're not communicating with each other. Okay, the ventricles are relying on their pacemaker cells that are scattered through the ventricles to override this lack of atrial stimulation. The ventricles say, we're not getting a rate or a conduction, so we're going to start our own rhythm. This can be severe bradycardia, eventually leading to decreased cardiac output. This patient would need a pacemaker intervention as soon as possible and monitoring. So you can see that there's varying levels of seriousness on these AV blocks, kind of going from worse to worse scenario, but all of these need evaluation by cardiology. All right, discussing atrial flutter and atrial fibrillation. These are a little bit different in their presentation. A flutter is pretty discernible where you can see the P waves. Thankfully, not all these P waves are conducting a significant impulse to the ventricular tissue. As if this were the case, sustaining a heart rate of 300 would not end well for this patient. So looking at the atrial flutter over here on the left-hand side, you have that sawtooth appearance on the EKG. These P waves are not conducting for the ventricle as far as which P waves are getting through. The way that this is kind of written out is you describe the atrial rate and the ventricular rate. So you have an atrial rate of 300, ventricular rate of about 75, and you could further characterize this flutter as 3-to-1 conduction atrial flutter. Okay. Cardiac output is essential in your treatment plan. So right now with a heart rate in the 70s, the patient's output is probably maintaining pretty well. But what happens when that heart rate elevates, or if more of the P waves start to conduct? A heart rate that elevates past 100 could lead to compromised cardiac output. So this atrial flutter, even if the patient is asymptomatic, does need evaluation, just as you would need to get evaluation for atrial fibrillation. Atrial fibrillation is chaotic. There's irregular complexes. It is more of a immediate interaction type of intervention that needs to take place, especially for a patient that's presenting with symptoms. When you're looking, the complexes, they don't really line up with the isoelectric line. Many times the P waves are indiscernible. So as you're looking here on the bottom right, it's kind of hard to see the P waves in the top one, whereas the bottom one, you can see the P waves pretty clearly. What the problem is with atrial fibrillation is that it's chaotic. We don't see a good reason as to why the atrium are causing this indiscernible shaking instead of nice pumping action. So you have a lack of good mechanical contraction of the atrium. Okay, there's too many impulses. The ventricular response, how many beats are happening through here? It's kind of chaotic too. There's some beats that are going through, some beats that aren't. And so this can be, leading to worsened outcomes where the patient gets short of breath, and they can lead to cardiac and pulmonary compromise. The risk for AFib development rises with age, and we see this arrhythmia fairly commonly in geriatric patients. But just because it's common doesn't mean that it's normal. So, if you see a 70-year-old, 75-year-old patient that presents with some shortness of breath and you see atrial fibrillation, and you say, oh, well, atrial fibrillation is pretty common in elderly patients, that's not normal. Okay, so common is not normal. Sometimes when you're doing your physical exam with atrial fibrillation, you can feel a pulse deficit, especially if you can see the heart rate is sporadic. What a pulse deficit is where you are feeling for a pulse on someone's wrist area and checking that radial pulse and listening at the same time the patient's heart rate. You don't feel as many pulses as you hear, and that's what's called a pulse deficit. So if that's the case, then that could be a good indicator for atrial fibrillation, especially if you don't have the ability to do an EKG at that time. Okay, now moving on to EKG practice. So I'm going to put up a 12-lead EKG up here that we're going to kind of go through together. If you want to print these out and kind of look at them as we're going through, that can be somewhat helpful. Okay. So first of all, we need to evaluate heart rate. Looking at this rhythm strip, sometimes it's easier to look at the bottom strip, which is the whole 10 seconds, or you can look at the varying sections, whether it's the main leads, AV leads, or the ventricular leads. So it kind of is up to you. We'll just look down here at the bottom, checking out how long it takes to get from one complex to the next, and it's about 1, 2, 3, it's about 4 complexes deep for each of these complexes. So it's probably about 75 beats per minute. That would be a good estimation on the heart rate. Looking at it, we have a P wave, it looks like, before each QRS. You can see and note it on the lead 2. You have a good showing of that P wave. So we got a P wave, which means this is an atrial arrhythmia, atrial rhythm. We have a heart rate of 72. This is looking like normal sinus rhythm. Okay. Some things that we want to look at as well as we're looking through these leads. We see a positive amplitude on leads 1, 2, your AVL. AVF looks a little negative, but it looks like we have a normal axis, so that's good. A PR interval, it appears to be less than 1 big block, so we're good there. QRS, all those look pretty tight, so that looks good. Now, looking at the ventricular leads, we start to notice this bunny ear pattern that we sometimes see with bundle branch blocks. And it looks like we could have that going on here. So looking at V1, 2, and 3, we can definitely see that right bundle branch pattern. We also see a deep T wave inversion. So that, can be disheartening over here on lead 3. So we got deep T wave on 3. The first 3 ventricular leads have that that finding that looks like right bundle branch to me. There may be some loss of accessory pathway conduction on this EKG. You would really need to see what's going on further with this patient. Cardiology consult would probably be necessary to evaluate the patient and make sure that everything is doing okay with them, because this is an abnormal EKG, normal sinus rhythm with right bundle branch block. Looking at any kind of ST segment changes, we want to look through all our leads to see if there's any ST elevation or depression, which on here I'm not seeing a significant ST elevation on any of these leads, so that's good. First look at this EKG, you notice right off the bat from the beginning of the strip there's a dropped QRS. Looking at this EKG, we're doing some sort of block, because as you're looking, there's 1, 2, 3 P waves that are not followed by a QRS. So that can definitely be some signs that there's some sort of heart block going on here. Okay. So looking at the heart rate of this patient, it's irregular because of the dropped rates. However, Most of the P waves create a QRS, and we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So we have about a heart rate of 75 beats per minute again on this EKG. As we are looking at the strip at the bottom, we see that there is a normal, after the first dropped, we see a fairly normal PR interval, a longer PR interval, an even longer PR interval, an even longer PR interval until it's dropped. So when we think longer drop, then we get a winky block. So this is a AV block, second degree Mobitz 1, or winky block. Okay, so heart rate 72, normal sinus rhythm with AV second degree heart block Mobitz 1. That's kind of how we would characterize this. Looking further at the EKG, we want to evaluate, is there any changes with T-wave flattening or inverting that we wouldn't expect to see. And the T-waves all look pretty consistent throughout. ST segment, we don't see a big ST elevation. We do see a pretty good isoelectric line throughout. And any pathological Q waves, nope, no pathological Q waves. So we have a normal sinus rhythm with second degree AV block Mobitz 1 would be a good way to characterize this EKG. Okay, moving on to this next EKG, we see a noticeable difference in the beginning of this 10 seconds to the end of this 10 seconds. We have, P wave followed by QRS over and over until we don't. And then we go into some VTAC over here to the right. You do notice that the wave kind of formation is that torsade de pointe that we talked about earlier, where the polymorphic changes go from really deep to more shallow to really deep again. This usually indicates some sort of electrolyte deficiency along with the conduction problem, and that this patient has ventricular tachycardia, which needs to be resolved through cardioversion shocking. Okay. Before that aberration, we do notice some changes looking at the waves. So over here I have TUP outlined. You can notice that there's a T wave, there is a distinct elevated U wave and a P wave. Most of the time U waves can be undetectable. They're kind of eaten up by the T wave and you don't really notice them. Whenever you notice a pronounced U wave, prominent U wave with ST segment depression, you're going to want to consider the likelihood that there may be some hypokalemia. Hypokalemia will often cause a prominent U wave. So looking at that here on the EKG strip at the bottom, you can see that this is a pretty tall U wave preceding the P wave. So that's kind of a key indicator that this patient might be developing some hypokalemia. I'm using a lot of these EKGs from the EKG library found on Life in the Fast Lane. It's a great resource for practicing EKGs, and you can do this on your own time if you want to look at some of these case scenarios. This case scenario gave some information about a patient, young adult female with eating disorder. Patients that have this kind of eating disorder often have hypokalemia, so it really does line up well with the case scenario data. Looking at P waves, PR interval, The P wave is less than one big block between the P and the R interval. So that's great. We do see a pretty good normal sinus rhythm up until we hit that torsade de pointe. So this EKG has a lot of different findings. Looking at axis deviation, we have positive amplitude on both leads 1, 2, AVF. So all of those look good as far as a normal axis until we get into the VTAC. A lot to read on this EKG. You can see how the T waves are really depressed throughout leads 1, 2, 3, AVR, left, and foot. All of them have really depressed T waves, which is also, something that you should see in a patient with hypokalemia. This 12 lead, we don't have the running lead on the bottom, but you can see quite a bit through leads 1, 2, 3, the augmented leads, and the ventricular leads. So looking for the rate, we do see a little bit of consistency between each of the complexes. They are somewhat regular, and they're about 2.8 big squares. So we're looking at a rate of about 108 per minute. So we got some tachycardia going on. It looks like we got P waves preceding every QRS. So this is an atrial rhythm, tachycardia, and it looks like some sinus tachycardia. Moving on to evaluation of other factors. This doesn't look like the patient's in cardiac arrest, so that's good. We don't have to shock or anything crazy like that. But what about some axis changes? Do we see any axis changes on this EKG? We got a positive amplitude in leads 1, 2, AVF is positive, so it looks like it's a normal axis. What about ST segment? So we're looking at ST, and we see a noticeable ST segment in lead 1, 2, and 3. You see the isoelectric line is where that P wave is coming off of. If you look at especially lead 2, I think it's pretty obvious to see the ST elevation between where the P interval is and how high up it goes to where that T interval, T wave is. We got some ST elevation here, so there's definitely some sort of cardiac process going on. We can look for pathologic Q waves. Looking for those. We don't see a real big Q depression throughout the leads, so that's good. But with having an ST elevation, one concern we have, of course, would be MI. This could be something else that's going on that's causing some cardiac irritation. But this ST elevation is no joke, so this patient would need to be seen immediately and need a thorough cardiac workup in the ER. Other considerations for this patient: they're in tachycardia. We want to make sure they don't have any type of fluid overload or pericardial effusion or something like that. These are some things that you'd want to think about with ST elevation. This is a pretty interesting EKG. Looking at your bottom rhythm strip, you have PQRST, and then you go into these wide QRS complexes. And then you go back to PQRST, and then these wide QRS complexes. So when we are looking at this rhythm, we notice that this rhythm is pretty extended. It looks like between the wide QRSs we have about 1, 2, 3, 4, about 5 blocks maybe just under, just below, depending on the QRS complex that you're looking at. So we have a rate of about 60. So this could be a junctional rhythm here. But what's interesting is that we go from this junctional rhythm to a few atrial beats. But looking at the atrial beat, we have the PR interval within that, one big square. So we know that we don't have a first degree block, so that's good. And but looking at it, that rate is just a little bit over 60 beats per minute. So it's a slow heart rate until we get to where that atrium doesn't fire off another beat. So in the middle of this bottom rhythm strip, we have 2 atrial beats, but between this atrial beat, there's 1, 2, 3, 4, 5, 6. The ventricle decides it's going to fire. It looks like there could have been a possible P wave right there before the ventricle fired. You see how there's just that little dip? But anyway, the ventricle decided that it was going to go whether or not it received a message from the AV node. So you have what we would call here idioventricular rhythm or junctional rhythm. So we have this junctional rhythm about 60 beats per minute. Looking at the rest of the EKG, we need to look to see if there's any ST elevation. We do have some depression, especially looking at leads V4, 5, 6, that kind of curves down. That could be, directly related to this junctional rhythm change and the kind of positive force that's going at the ventricle. You're going to see a higher intensity voltage on those amplitudes, looking at those complexes through V3, 4, 5, and 6, and then it depolarizing. So this is just an interesting junctional, idioventricular junctional rhythm. We don't see an ST elevation, so that's good. And as far as pathological Q waves, we don't see that huge dip. We just see, a ventricular paced rhythm intermittently. So there's obviously some type of conduction problem with the atrium and the ventricle, but this isn't a heart block issue. There's a conductivity issue with the atrium where it's not firing fast enough, and the junctional failsafe is firing. So this patient would need to be evaluated by cardiology to see why they have such a low heart rate. Could be from medications, could be from any number of causes. Okay, this EKG, we see a nice little pattern on our bottom rhythm strip. It's that sawtooth flutter pattern that we've seen before. What's interesting about this flutter is the R to R intervals have a varying rate. Some of them you see have 2 flutter waves before a QRS, 2 flutter waves QRS, and then others are 4 to 1. So it goes 2 to 1, 4 to 1, 2 to 1, 4 to 1, 2 to 1, 2 to 1, 4 to 1, 2 to 1. So this kind of pattern can be interchangeable. I wouldn't call it irregularly irregular. I think that you could best define this as a atrial flutter with 2 to 1 or 4 to 1 conduction ratio. Looking at the rate, it's a very fast rhythm. You have on the 2 to 1s, you have about 3 big squares between them. So that's 300 divided by 3. That's at least 100 beats per minute. So we have elevated rate, and we know our rhythm is going to be A flutter. Looking at the other parts and aspects of the leads, lead 1 and 2 are mainly positive, so we don't have an axis deviation. I don't see any ST elevations. It's a little difficult to see T wave abnormalities because of the flutter waves. And I don't see any pathological Q waves. So this is atrial flutter at a high rate, anywhere from 100 to 120 beats per minute. Now, if this had a more consistent morphology without the 4:1 ratio, we would see an even faster beats per minute rate. Okay, this EKG is chaotic. That's the first thing that I want you to think of when you see this EKG. It's all over the place. Looking at the rhythm strip on the bottom, there's no isoelectric line. It goes down, it goes up, and it goes back down. There's no discernible complexes. It's all over the place. Differentiating this measure, which we're going to diagnose this as VFib versus AFib. In AFib, sometimes you'll still have ventricular complexes that pop up. This is a definite VFib though, where there's no discernible complexes looking at the rhythm strip on the bottom. And it's just chaotic. So this patient needs shock therapy as soon as possible, and they probably are undergoing ACLS measures with CPR and everything. I've circled a few of the items here on this EKG because I think it's a little bit harder to read this one. It's not as clear. So looking at this EKG, we go down to the bottom strip, just kind of looking overall. This bottom strip is actually V5, which gives us a pretty clear show of what's going on. You can see how there's P's, but some of the P's do not have a QRS complex behind it. So we are dealing with some sort of heart block issue here, okay? And we know it's not first degree because at least with first degree there would at least be a QRS with all of them. So we're looking at a second or third degree block. Trying to differentiate it, second degree AV block, if this was a Mobitz 1, we would see a longer drop winky block, and I don't really see that here. If you're looking at the P waves before the QRSs, they're all pretty consistent throughout, so I don't think this is a winky block. And as you're looking, we mostly see P's that are followed by QRSs, and they line up pretty well. It's not chaotic as you would see with third degree heart block. So this is a second degree AV Mobitz 2 block. Looking at the heart rate, if we had, all of these conductions going through normally, we would be a normal sinus rhythm, but because there's so many blocked depolarizations of the ventricles, we're getting a little bit bradycardic here. Also noting, I have these two places circled. Lead 1, you have that nice little slope after the QRS complex, that sloped and slanted ST and T wave that we sometimes see with right bundle branch block. As well, you see that kind of rabbit ear bundle branch block look M over on V2 and V3. So we're looking at a right bundle branch block, second degree Mobitz 2. What about the axis? Do we see any kind of axis deviation? We have a positive lead 1, negative lead 2, and negative AVF. So this looks like a axis deviation to the left axis. So left axis deviation. As far as, is this going to be a lethal arrhythmia? This could definitely worsen, and the patient probably needs pacemaker. When you're looking at Mobitz 1 versus Mobitz 2, Mobitz 2 patients generally need intervention at a sooner time compared to Mobitz 1. And pacemaker may be necessary, maybe temporary pacing, but that's something that cardiology would need to decide. Okay, looking at this EKG, we see a whole bunch of up and down patterns. So before you start thinking that this patient has, a whole bunch of QRS complexes, you should realize that these are pacer markers. Okay, so a pacer spike is going to be shown through the EKG with a line that goes up and down. So you can see where a pacer is as far as that electrical conduction is initiated, and it should be followed by a QRS complex. As we're looking at this bottom line, you can see how there is a failure to capture here, or a failure to sense. So when we're talking about failure to capture versus failure to sense, we're talking about the pacemaker's ability to react to what's going on with the heart, whether it's sensing or whether it is able to capture the heart and capture a depolarization. So in this instance, we have failure to capture because some of the pacer spikes are followed by a QRS complex, whereas others are not. And it's almost in a 2-to-1 fashion where we see a spike with the first one, and then for some reason the pacemaker is sending out a spike almost immediately afterward. This may be where the pacer isn't sensing that initial QRS complex, but this can be very problematic for someone that has this pacer if they are not capturing complexes. Failure to sense is where the pacemaker is failing to sense that there's a need for a pacer spike. So, if you have a patient that relies on pacemaker and the pacemaker isn't sensing that conduction is necessary or needed, then the patient isn't being paced even by the pacemaker. So a lot of times patients with pacemakers may need evaluation, especially if they come in with shortness of breath, syncope, lethargy. These are some symptoms that someone like this might be experiencing when they come into the office. Looking at axis, we have a positive 1, 2, AVF looks a little negative, but we have a somewhat normal axis. Looking at other findings, you do notice here in the first really 2 seconds of the strip that there's a big wide QRS complex. That's a ventricular complex there. So this could be premature ventricular contraction. It could be that there was actual a junctional rhythm taking over because there wasn't a nice big contraction before, but this looks more like a PVC to me, especially since it's singled out. Premature ventricular contractions can be quite normal in some populations, even in younger adults in their 30s and 40s. They tend to become more common in elderly years, but premature ventricular contraction, if just seen every now and then, it's not a big deal. If we see them over and over or in running beats, then we start to become a little more concerned about these ventricular contractions. This patient needs evaluation to see why this pacemaker isn't working correctly. We'll go ahead and end this practice session with this last EKG. As I said in previous slides, if you want to practice more EKGs, there are a lot of online resources like the one that I have listed, Life in the Fast Lane, in the reference section. So you can always look into that if you're interested. Practice is going to make you into a better EKG reader, and it's really going to help you in making better decisions for your patients. As you're moving through the program and starting to make more and more decisions for your patients, it's important that you're able to interpret an EKG and provide the necessary intervention for whatever kind of finding is coming into your office. I'm going to make another short lecture talking about some different things that you'll be doing when interpreting EKGs in the clinical practice setting, so you can always listen to that whenever you feel like it. It's going to cover a lot of things that we've probably already talked about, but I think it's necessary just to go over it one last time. For this EKG that we're looking at here, looking at the bottom long lead, that's lead 2, showing us a lot of beats per minute. Looking at the space between each complex, it's about 2 big squares, so 300 divided by 2, we're looking at a rate of about 150 beats per minute. As we see, there are some P complexes that are easily seen. Lead 1 really shows some of the chaos that's going on because this is atrial fibrillation. You can see in lead 1 there's a lot of shaky fibrillation, and there's a lot of P waves, and not all of them are getting through. So with atrial fibrillation, we're going to need definitely our patient to be seen, especially if they're very symptomatic or this is a new diagnosis, so that we can get them on some anticoagulant therapy and get their rhythm and rate under control. Someone that has a heart rate of 150 beats per minute is not going to be able to sustain that for a long period of time. So this patient needs to be admitted to the hospital for further evaluation and treatment. Looking at axis, we have lead 1 and 2 and AVF. That's all positive findings. This looks like a normal axis. I don't see any Q waves that look compromising, and the ST segments all appear pretty normal. And even for an AFib, we don't see a lot of up and down for the isoelectric line, so that's good. So this patient needs to be admitted for further evaluation, and we got a atrial fibrillation at a rate of 150 beats per minute. I look forward to any kind of feedback that any of you might have about the lecture. If you have any questions, you can always feel free to email me at stigersa@nsula.edu. I'm happy to provide further direction if necessary. Y'all have a great rest of the day.